Hello, hi, good afternoon, doctors, ladies and gentlemen. My name is Fazuli, and on behalf of Picasso Hospital, I would like to extend a warm welcome to all of you for joining us today for the very first Picasso Hospital semi-session on the topic Improving Cancer Outcomes, Advances in Surgery for Colorectal Cancers. Picasso, which is stand for PJ Integrated Center of Advanced Surgery and Oncology, is located at Section 14 Petaling Jaya, and we are target to open our doors this year, Q2. Our focus is on robotic surgery and cancer care. All right. Today we are honored to have Dr. Luqman Mazlan, an esteemed colorectal and general surgeon. Dr. Luqman's expertise will enlighten us on the latest advancements in colorectal cancer surgery, contributing significantly to improve patients' outcome. Before we start the session, let me introduce our esteemed speaker, Dr. Luqman. Serving as the President of Malaysian Society of Colorectal Surgeons and the Vice President of Parenteral and Enteral Nutrition Society of Malaysia. Dr. Luqman Mazlan also actively engaged in research, education, as well as international trial. His many published works in peer-reviewed journals highlights his commitment to advancing colorectal surgery and clinical nutrition. Without further ado, I would like to invite Dr. Luqman to share his insights on improving cancer outcome through advances in colorectal cancer surgery. Dr. Luqman, the floor is yours.
Thank you, Fazuli. Just let me share my screen. Here we are. Right. Thank you, Fazuli, and thank you, Doc Quitty, for the inviting me here and for the very kind introduction. It is indeed a pleasure to be here and to share with you what are the latest advances in surgery for colorectal cancer. Now, without much ado, I'll just begin, and I'll be very glad to get any questions at the end of this talk. So I'm currently the president of the Malaysian Society of Colorectal Surgeons, and I'm actively involved with the treatment of colorectal cancer. I don't have anything to disclaim. Now, the outline of my talk will be just as a reminder to all of you, and I'm sure many of you have attended many talks on colorectal cancer, but I'll just, as a reminder, go on to the general concepts with special regards to surgery, and then we'll talk about laparoscopy for the rectum, the colon, because for the colorectal surgeon, these two organs are distinctly different in the way we manage, and they have their own different set of challenges. And then I'll be speaking about transanal surgery, which is basically surgery through the anus from below. And robotic surgery, obviously, as what Fazuli mentioned, is a core part of our work. And then whatever mentioned prior to this was minimally invasive surgery, but I will be talking about exenteration surgery, which is in many ways maximally invasive surgery. And we are really pushing the borders of this because we want to aim for a cure and a quality of life. So I will go on to this as the talk goes on. Now, as a reminder, you know that in Malaysia, colorectal cancer is the second most common cancer, only because breast cancer is way more in the female. But in the male, you can see that colorectal cancer is the most, and in the female, it's second. Now, the sad thing about all this is that because we don't have a screening program, most of our patients, you're talking about 25% of patients, tend to present late in either stage 3 or stage 4. And until a point of time where we can adequately screen a majority of the population, I think surgery advances needs to be at the top of the top quality to ensure the best outcomes for our patients. And I'm sure you know that like any cancer, if you catch a cancer earlier, the risk of cancer recurrence reduces, the overall survival increases, And that is the same for colorectal cancer. Particularly important is the quality of the surgery. And with technology nowadays, the outcomes are improving significantly. Now, when we talk about outcomes after surgery, particularly about colorectal cancer, everybody talks about oncological outcomes, which actually should be the main concern. But a very big outcomes that people also talk about is the functional outcomes, particularly with rectal cancer, where when we remove the rectum, and you and try to save the anus, because the anus is needed for continence, and therefore the function of the anus and the rectum is important. And you remove the rectum, then the patient does not have any more rectum, and then the patient will have all the symptoms of increased frequency, diarrhea, and all that. And I will explain that a little bit more later. Now, as you can see, the rectum is a reservoir, and it's like a room. And when the stool collects in that room and the rectum expands, it tells your brain that when the room is full, it's time to go to the toilet, and that's when you evacuate. But when you remove the rectum, that room gets significantly smaller. So the reservoir capacity of the rectum is much reduced. And then these patients can can only store a little amount of stool before they start rushing to the toilet. So they have this problem with increase in frequency of going to the toilet, not able to keep it for long, and not to mention, because a lot of nerves are cut, particularly in the old days where technology is not so good for us to visualize the nerves. So we tend to cut a lot of nerves, and these patients don't do so well, not only with this reservoir function, but also with the sexual and urinary function. Now, a little bit of the principles of the surgery for the colon. When the tumor is on the right side, we do a right hemicolectomy, and we don't only remove the colon, but we remove the blood supply and the lymph nodes that come with it. And then we do a left hemicolectomy if the tumor is anywhere in the distal part of the transverse colon or in the descending colon. And if the tumor involves the sigmoid or even up to the upper rectum, then we perform an interior resection. Now, what I mentioned earlier is that the principles of our surgery is to remove the blood supply together with the colon, and only because the lymph nodes that follow this blood supply is very important. And if we just remove the colon without removing the blood supply, then we leave lymph nodes behind. And if the cancer enter the lymph nodes, then obviously the risk of recurrence is very high. And this is what the specimen should look like for us surgeons, and particularly for the pathologists who will report. You can see this is a picture of the colon, and you can see the fat of the yellow part, which is encircled in blue, and that contains the lymph nodes. So it's very important for a good quality of surgery and a good surgeon to take out all these lymph nodes. And it may not be easy because all these lymph nodes are all very attached to very important organs here. So you can see this is the duodenum, and this is the superior mesenteric vein, which is the main venous supply to the small intestine. And if we were to injure that, then it could be disastrous. The patient could lose the small intestine and die. So I think it's very important that that meticulous surgery is crucial here, and a high amount of technical skill. Now, this concept is brought also to the rectum. As I mentioned, colorectal surgeons tend to think of the rectum differently from the colon, only because the anatomy is a bit different, being the rectum is in the pelvis. But the general concept that is similar is that when we remove the rectum, we cannot only remove the rectum alone. You've got to remove this yellow picture here, which is the fat, because it has lymph nodes. All right. And this plane, this red line here, this is called the total mesocolic. Sorry, that is called the mesocolic plane, right? So when we do a total mesocolic excision, this is what we aim for. A long time ago, you're talking about the 1970s and 1980s. Surgeons used to just cut out the rectum, leaving all this fat behind. And what they find is that the tumor comes back very quickly, and that's not good. And the person who created, or who rather who found this concept or described this concept, was Bill Hill in 1982, where he started this concept of TME, where they found that if you did this by removing the plane, number one, you have less bleeding, but number two, the recurrence rate drops significantly from what it used to be 60-70% to less than 10%, and with a 5-year survival of up to 80%. I had the pleasure to meet Dr. Hill a few years ago, and it was quite an interesting conversation I had with him. So this is what a rectum looks like when we remove it. As you can see, the fat that surrounds the rectum, and it should be like that. And the pathologist will know whether a surgeon is good or not based on how much fat is removed entirely. I mean, if the surgeon gives a specimen with full of jaggeds and full of bare rectum, then you know that a lot of lymph nodes are left behind, and he's not doing the surgery right. So that is the principle of rectal cancer surgery and colonic surgery. Now, the other important thing you all have to appreciate is that the difficulty in operating on the rectum is that the rectum is placed in the pelvis. Now, particularly in the male pelvis, which is very narrow, because of course the female pelvis is bigger, because it has to make space for the baby's head during pregnancy and delivery. But in the male pelvis, it's very small, and it is as big as a Coca-Cola can, like I mentioned here. And I mean, I'm not trying to endorse Coca-Cola. I shouldn't be right now with the war and everything, but essentially, this is how big the size of the Coca-Cola of the male pelvis is. And if you have a tumor, like in this black circle here, and you're trying to remove it, it may not be very easy. Okay, so this is just for you to appreciate size. Now, so one of the challenges here in rectal cancer surgery is how low can we go, trying to preserve this purple structure, which is the anal sphincter. Now, everybody, if possible, would not like a stoma. A stoma is something that is not what people want, particularly if it's a permanent stoma. When I say how low can we go, meaning how low can we remove the rectum while preserving the anal sphincters? And it is really technology that helps us go lower and lower, trying to avoid the patient getting a permanent stoma, right? And then the other concept is how wide can we go? Because in the pelvis, there are a lot of other organs like bladder, prostate, seminal vesicles, the uterus. So all this, if the tumor is involved, then what can we do? In the past, we give up. We say, look, this is it. It's too big. We can't do much. But I will show you later that surgery has really improved with time, and we can offer the patient much more. Now, I think surgery, like any surgery, always starts with open surgery, which used to be the main kind of surgery that was done. And we still do it. I still do it in an emergency situation where it is impossible to do minimally invasive work, right? So, but the trouble with open surgery, now, just as a reminder, the concept of the tumor removal is the same, like what I mentioned inside, whether it's minimally invasive or open. It's the access to the abdomen which makes a difference. And the thing with open surgery is that obviously it comes with a wound complications like wound breakdown, wound infections. Over the long term, these patients get incisional hernia. They stay longer. Patients with an abdominal wound like this, my patients generally stay up to 2 weeks, whereas if I do minimally invasive, they go back within 3 to 7 days, and it's really, really quick and cost saving in the long term. Also, technology has made the surgery more consistent. In the past, we used to hand sew most of our anastomosis, but nowadays, with the use of staplers, the surgeries are quicker, faster, more reliable, although they cost a little bit more, but it makes the surgery so much easier. And these are all the things that we use as surgeons to cut or join the intestine. So this is an example of the staplers that we use. And you will see that it's not only to make the surgery faster, but it allows access into the deep pelvis, which is very small, and it's these devices that will help us. Otherwise, it will be impossible to join the intestine very deep down in the male pelvis without these devices. The other thing that technology has improved is even in sutures, where it used to be a long time ago, people used to use catgut for everything. And then now, of course, we have other more modern sutures. But now we have antibiotic-coated sutures to reduce the risk of infections. We have sutures that are very strong because they're like an arrow. They go in and they don't come out. So they are unidirectional. And that makes the surgery safer. The wound is the risk of the wound gapping or dehiscence is much less, right? So I'll speak about laparoscopic surgery first. I know this is not something new. It's been around since probably about 25 years, but technology has improved throughout time. Now, these are the port placements. Basically, these are the wounds that are made. You can see that they are ranging from 1 centimeter to half a centimeter, and it's very, very small. Okay, so this is what I put into my patients when I'm performing this surgery. There are about 4 or 5 ports, depending on where the tumor is. So essentially, like what I said, I remove the tumor together with the fat, and then I have 2 ends, and then I have to bring these 2 ends together. And sometimes it's not easy to stitch it by hand. So with technology, it is so much easier with a stapler to join the bowels using this device. All right. Now it's very safe, and you know what is the concern with regards to joining bowels? Is there a risk of a leak? And with these devices, the risk of a leak is so much low. It is quite low, and you're talking about a leak rate of less than 5%. So I mean, there's nothing in medicine is 100% or 0% when it comes to leak. Even the best surgeons have leaks, but we try to minimize it with using these technological advancements. And as you can see, one of the advantage of laparoscopic work is that you can go deep in the pelvis. You can see, especially with high definition 4K screens, all the different structures, the muscles, the nerves, and you can separate it and try to avoid injuring them. And I won't bore you with too much data, but because laparoscopic surgery has been around for so long, all these trials all around the world have shown that in terms of oncological outcomes, they are comparable to open surgery. And in terms of the overall oncological outcomes, in terms of the overall length of stay, obviously, patients who undergo a minimally invasive technique stay in the hospital much shorter. Now, when you talk about advances of minimally invasive surgery, then I have to mention about these 3 things: intersphincteric resection, TAMIS or transanal minimally invasive surgery, and then something called a transanal TME. And I will just go briefly into them. Now, as you know, as I mentioned earlier, one of the core things that we try to do for our patients is to save their anus, to save their sphincter. And how we do that is we remove the tumor as low down as possible. And if the tumor is in the lower rectum, we can do an ultra low anterior resection. Ultra low because it's very low, it's below the pelvic floor. Now, what happens if the tumor involves part of the internal sphincter? Then we do a surgery, which is called the ISR, or the intersphincteric resection. So it goes between the internal and external sphincter just to remove the internal sphincter. Unfortunately, if the tumor is very big and it hits both internal and external sphincter, then this patient would have to lose its anus, their anus, and we can't save the sphincters, right? So with regard to intersphincteric resections, why I say it's a technological advancement, because this is not possible in the past when you don't have very good high definition 4K vision, if you don't have the robot, if you don't have good smoke evacuation, because when you operate, there's a lot of smoke. And if you don't have all these technological advancements, you will not be able to see the structures very clearly. So this is the abdominal perineal resection that happens if the tumor involves both the internal and external anal sphincters. And we have to close off the anus, and it looks like this. And then the patient has a permanent stoma. But when we do an intersphincteric resection, and the tumor is there, for example, as illustrated in this black dot, then we go in between the internal and external sphincters, in between the pelvic floor, and try to go below the tumor, trying to save the external sphincter at least. And I will show you here how it looks like, and then we will join the bowels together. Now, when it's so low like that, it's impossible to use a stapler, and we would have to hand sew. Okay, so this is a video that you can see here. Sorry. Maybe I will just go and play my video now. So this is a video of the rectum, and it's very, very low. Now, you can see these are the pelvic floor muscles. And it's only with technology where we can see these muscles and very, very clearly, right? Because with old video systems, you cannot really see what you're cutting, and you're just cutting everything. And then there's bleeding, there's smoke, and you might even cut into the tumor, and that's really bad. Okay. So it's really technological advancement that help us see the structures. And you can see this is the intersphincteric plane. This is the the external sphincter, and the internal sphincter is part of the rectum, and then we can cut there, right? So now once we've cut it, then we actually work from below, where we can actually close off the anus, and then we cut into directly below the tumor, and cut through the mucosa of the anus. And then what we do is that we will deliver the specimen through the anus. I will show you here. So you see this is the whole colon that comes out from the bum. And we use this technology to see perfusion. I'll talk about it later. And then we transect it there. And then what we do is we actually sew back the colon to the very, very end of the anus. And you'll be surprised that this patient, because we preserve the external sphincter, they have some amount of continence. This is never as good as before surgery, but at least they don't need a permanent stoma. If anything, they have a temporary stoma just to protect the anastomosis. And the stoma only lasts at the maximum about 6 months before we can reverse it. Right? Now, this is so important because what we found when I was in UKM a couple of years ago, was that when patients undergo chemoradiotherapy and they feel better, come back for surgery because they are so scared of a permanent stoma. And the trouble with up to quarter of them who don't come back, the trouble is that in 4 years, only 10% of them survive. And if we can convince them that we can save their anus and they don't have a permanent stoma, I think many of them would agree to the surgery and come back. So I think that's very important. Now let's talk about transanal surgery, because that's also very new. In the past, I would say 10 to 15 years. But with technology, it has picked up. As I mentioned, the pelvis is very small. Sometimes you have a big tumor, you can't go below it from inside, and you have to approach it from below. And we use special devices where we put something into the anus, like a platform which is connected to air, and the air will insufflate the anus and the rectum so that you have space to operate. right? So the patient is placed in a position, and you can see this is me doing that surgery, and we have this gel-like platform that enters the anus and is connected to a screen. And essentially, what we're doing is we're removing the tumor. And this was first described by my friend Sam Atolla in the US, I think in the Cleveland clinic when he was there in 2009. And you can see that if you have a small tumor, it's easy to remove it using these instruments and then stitching it back. So in these patients, if the tumor is small, they don't need a big surgery, and they can go home the very next day. And this is how the tumor looks like when we put it on a board. But this is only for certain tumors. You're talking about small tumors where there are no lymph nodes. And as I mentioned, these patients don't need to stay very long. They are safe from a big operation, right? Now, what is transanal TME? It's really combining that technology, that capability of operating from below to remove the entire rectum. And why it is important? Because the male pelvis is so small and the tumor is so big, and it's so difficult to go underneath it from the top. Sometimes we have to remove it from below. And this is how we do it. We do a stitch, we close off the rectum from below. And as a reminder from this earlier slide, we try to remove the rectum together with the fat and lymph nodes, but instead of doing it from above, which means inside the abdomen, we do it from below through the anus, right? So this is how we do it. But this procedure is not easy, definitely, because you risk injuring a lot of structures like the ureters, the blood vessels of the sacrum, the bladder, the urethra. So it does take a very high learning curve to learn. And once we've done that, then we remove it also through the anus, and we can this time use a stapler to join it down. Right. So that is transanal surgery, and it does help, particularly with smaller tumors. Now, there's a lot of hype about robotic surgery, and robotic surgery is not new. It has been around since 1999, but technology has improved so much that our current robots, and mind you, the current robots have been out for the past almost 10 years, but and I'm sure that the next generation is due, but it takes about 10 to 15 to 20 years before a new generation comes out. And a lot of changes has been achieved. Now I'll just go through quickly. What are the benefits of robotic surgery? Number one is that you can see very clearly, very good ergonomics for the surgeon. I'll show you later. The learning curves are not too high, and enhanced motions, and I will elaborate on this further. Number one, the surgeon is actually sitting in a console away from the patient, and he is controlling the robot with his hands. Now, this is not the robot operating on its own. Well, hopefully by the time I'm 70 or 80, that might be possible, but not now. The surgeon still has to control the robot. But the difference is that you don't have any more tremors. Very, very fine movements can be done. When you move your hands a lot, the robot moves only a little bit. So it really does makes the surgery much more gentle and much more meticulous. And as you can see, one of the advantages of having a robot is you can go very, very deep into the pelvis. You don't have an assistant holding the camera for you. And the robot has 4 hands, whereas you only have 2. So you can do so much more with 4 hands, trying to push away important structures and whatnot. Okay, so that's the advantage of robotic surgery. The other thing that is important is when we do keyhole surgery or laparoscopic surgery, we use devices that are straight. So if the devices are straight, sometimes you don't have that wrist movements where you can move right and left like in your normal hands. And as I mentioned, the surgeon only has 2 hands, At most, he has an assistant with another two hands. So you have four hands, but they are not in sync. Whereas in a robot, you can control all four hands by yourself as a surgeon. And you have this wrist movement, which the instruments can go up to 45, 90 degrees, and that really helps a lot with the dexterity and trying to get over the big tumors. Of course, this is the future. This is a picture of a single port robot where they just put a camera through just one port, and then the surgeon controls that, and then um, you can do the surgery through one, and you can see that wrist movements, and this is possible with technology, and I think that this will be the future. As I mentioned, ergonomics is very important. I mean, I'm relatively young, I think, but when I'm 60 or 65 and I still want to operate, it may not be easy to do laparoscopic surgery, particularly if the OT is not set up for it. And I can see here, I'm twisting my neck, which should not be the way. But if you have a robot, and my good friend Chong Hun Yin from Sunway is showing here, he's sitting down very comfortably, and he can do this surgery very, very safely. And after that, he can go back to his ward rounds and all that without feeling sore, because these surgeries may be very tiring. And I realized that after 3 or 4 hours, then the rest of my day is gone. This is the technology of other robots that are used to enter the colon, for example. These are all very new. Not only used for colorectal, obviously, they're used for ENT and other things. But this is one of the many other robots that I have tried. Now, like anything, is there evidence for a robot if laparoscopic is so widely accepted? Now, I think you all should know that in Malaysia, the only coverage that the insurance are willing to pay is for prosthetic work for urology. Although the urologists are pushing for more and expanded different other techniques, I mean, other surgery, like removing the like nephrectomies, for example. And also the gynae fraternity is fighting for hysterectomies and some other gynae surgeries. But when it comes to colorectal work, it is still not covered. There are studies ongoing which are trying to prove the added advantage. Now, when you're talking about cancer surgery, they always talk about oncological outcomes, functional outcomes, and also length of stay and the complication rates. And currently, there is no strong trial that says that robotic surgeries is an advantage for the patient. It's definitely an advantage for the surgeon. However, um, uh, preliminary studies have shown that at least robotic surgery has its potential, particularly with technically challenging cases of a huge tumor in a male pelvis, right? So this is a very classic trial that all robotic surgeons were introduced many years ago, which did not show any advantage over standard laparoscopy. But there are weaknesses in these trials, and that currently there are a lot of ongoing trials which is trying to dispel this landmark study. Right. So now I've talked a lot about minimally invasive surgery. Now, what about maximally invasive surgery? I mean, because our tumors here are so big, what can we offer in patients whose tumors are very locally invasive and they involve a lot of other organs? Now, an exenteration is removing of the tumor together with all the other organs involved, right? And the aim of this surgery is to remove the tumor entirely. If you leave a little bit behind, whether microscopically or of course, if it's macroscopically and you leave a big chunk of it behind, then the tumor will come back. But even if you remove a little bit, if you leave it a little bit behind, it will come back. So the aim is if it touches something, you have to remove it. So this is a picture. If it touches the uterus, remove it. If it touches the bladder, remove it. If it invades the bone, remove it. And so this is what the concept of this surgery is. And basically, when you remove the rectum with the uterus, cervix, and vagina and the pelvic floor, that's called the axial exenteration. If you remove the bladder, prostate, and the pubic bone, that's anterior exenteration. If you remove the sacral bone, that's posterior. And if you remove laterally all the nerves and the vessels, that is the lateral exenteration, which is the most difficult kind of exenteration to do. If you remove everything, then that's a complete pelvic exenteration, which is what some people do. And I was trained in Australia for this, but in Malaysia, one of the difficulties of getting these surgeries done is these surgeries need a multidisciplinary effort and team, and they take very long. You're talking about the almost 18 to 24-hour surgery with 30 bags of blood needed. So these are really huge surgeries. But if they're done properly, these patients have relatively good quality of life. So we don't do it if the patient has distant mets, if it involves the common external iliac vessels, in mets to the lymph nodes that are way beyond the pelvis. Okay, so we don't bother, because then these patients are palliative. And if you do big surgeries like this, they show no added benefits. Right? So this is the pelvic floor, and if the tumor involves the rectum, then we removed the pelvic floor. But if the tumor involves the prostate, then we have to remove everything, including the prostate, and the patient will have a permanent stoma as well as a permanent new bladder. So you have two bags, one for urine and one for colon. Not many patients will accept it, but if they do, they can be cured free of the cancer. Sometimes if the tumor invades the bone, you can't get away with it, then you remove part of the pubic bone. Now, people say then the patient won't be able to walk. That's not true. They can. They walk with a waddle, with a little bit awkward, but they can live. And this is a picture of the pubic part of the pubic bone removed in a patient that I operated a couple of years ago. Because the defect is so big that we need a plastic surgeon to create a flap to cover the anus, and then this patient and this is a picture of very good wound healing, right? And you have huge tumors like this that involves the sacrum, then we actually have to remove part of the sacrum. And if it's below the level of S3, S2, then we can do it on our own. But if it's higher up, then we might need the help of our orthopedic spine specialists, consultants who come in to help us remove it in a prone position. Right? So this is a picture of one of the cases that I did, removing it. This is the hardest type of exenteration, where we remove tumors that are in the lateral pelvic wall, only because there's so many structures there, the veins, the arteries, the nerves. And we really have to delineate all this, and then remove the tumor. And this is how it looks like once we delineate all the anatomy. So the yellow here is the ureter, and the red here is all the vessels. This is the external iliac, and this is the internal iliac, right? And we tie off, sorry, the external iliac vein, and we tie off all the, we actually tie off the internal iliac artery and veins. Essentially, this surgery is not for the faint-hearted, and you actually need to be brave. Thankfully, we don't need to do this very often, but this is something that we do if the patient requires. And with experience, the RO resection rates are high, particularly if they are just in the axial regions. You can see when it first started about 20 years ago, it was only 21 or 49% 21% in the lateral exenteration was successful in getting an RO resection. But now that has increased. But this is in the best centers in the world. And in Malaysia, I think we only achieve in the lateral exams probably less than 50%. Now, some of you may ask, it's so morbid. Why would you want to do this? Is it worth it? Now, there are obviously a lot of groups and studies that look at it, and they say that these patients, if you achieve an RO resection rate, although the complication rates are high, these patients have a improved quality of life compared to if you don't do anything, which they will die very quickly. Now, a little bit about what we use to help us make surgery easier. There's something called indocyanine green, where we inject this green into the veins and the patients end up like Incredible Hulk. And with a special device, we can see how well perfused, for example, the colon is, so that we know where to cut. Because if we cut colon or rectum that is not well perfused, what's going to happen is that it's going to die. And when it dies, it's going to leak. So ICG actually helps us tell us exactly where to cut, because we want to cut where there's a lot of blood supply. The other thing that we can use ICG for is to help us identify the ureter, which is a very important structure in our surgeries. If you injure the ureter, then these patients, you need to refer to a urologist, need to repair this morbidity. So we try to avoid that by putting a stent in, which we call it a lighted stent, because if you use the ICG, you can actually see clearly here the ureter, and you avoid cutting into it. And it's very useful for big tumors, or even for the gynecologists when they want to remove the uterus. I'm very happy very proud to say that I'm also part of the international study with my friend Professor Ito in Japan, who is coming up with a artificial intelligence program where we feed this algorithm with thousands of surgeries for the rectum into this program, and the algorithm will then tell us what structure is what, so that for future surgeons, they will know what structure is there in front of them so that they don't cut it, right? For example, you can see this purple picture here. There's a prostate. And if the computer tells us that's a prostate, then the surgeon will not cut it. So there'll be less bleeding. Similarly, this green picture shows the posterior part of the rectum, and you try to cut within that green area and not beyond it. So this is the future of surgery. It makes surgery safer, so that we don't have complications for the patients, and the patients do better. And at the same time, it does improve oncological outcomes. So just to quickly end, I have talked about the general concepts of surgery for the colon and rectum. I have talked about the advantages of laparoscopy surgery, and the advance of transanal surgery that helps in the very, very low tumors. If they are very early, these patients are safe from major colonic resection. I've talked about the advantages of robotic surgery, particularly in the deep pelvis, in a male, in a big tumor, with the advanced dexterity, the clear views. There is definitely an advantage for robotic surgery, even though the evidence may not be strong currently, but I'm sure it is a coming. There'll be more data on that in the next few years, and hopefully we can convince the insurance companies to help pay for the patients. I've talked about exenteration surgery, very morbid, maximally invasive surgery. It may be necessary, and it's only with time and understanding of the anatomy that we have actually pushed the boundaries of how much we can remove. But it really depends also on the patients, whether they are willing to go through this. And also some upcoming technologies like ICG um, and the new robotic techniques and artificial intelligence that's coming. So before I end, thank you very much. This is the society that I represent. We are the Malaysian Society of Colorectal Surgeons, and there are about 100 of us, well, less than 100 of us around the country. Most are in the Klang Valley. And I'm very honored to to help lead this society. And every year we have a conference. This year we have a conference in Shangri-La, and it's entitled Humanizing Technology, which is very much in tune with what we have spoken today, the advances of technology, but really how do we use technology to help our patients and make patients and the treatment of cancer better. And of course, for those of you who are in the East Malaysia, I'll be the organizing chair of a very big conference, Asia Pacific Conference in 2025 in Kota Kinabalu, where we'll get a few hundred or 1,000 perhaps colorectal surgeons from around the world that will be gathered in Sabah in 2025. Right? So thank you very much. This is a short message from Picasso. I'm going to go and work there. I'm not there yet, and I look forward to be working with Fazuli and his team in Picasso. Thank you very much.
All right, thank you, Dr. Lokman. Okay, following to Dr. Lokman's presentation, we have a dedicated question and answer session. Hopefully, feel free to submit your question right now. If you have any, we can address your question as many as the time allow. Right? If there is no question, all right. In conclusion, I would like to express my gratitude to Dr. T as well as Dr. Lokman for his valuable contribution today. Thank you, Dr. Lokman, and thank you to all participants for joining us today. And we hope you find today's session informative and relevant to your practice. Please stay tuned for our future session and have a wonderful afternoon. Thank you, everyone.